Visit licensureexams.com and try our samples completely free of charge.
Welcome to the Licensure Exams podcast, you lovely therapists. You know that little mental nudge when things aren't quite right? Like books on a shelf? You know, double-checking the stove even when you're pretty sure it's off.
Yeah, we all have those little quirks, those moments.
Right? But what if those feelings, those urges become, well, constant, really overwhelming? That's kind of the area we're getting into today.
Exactly. A lot of you listeners have asked about the difference between, everyday tendencies like that and maybe more formal conditions. So today, we're doing a deep dive into two specific ones: obsessive-compulsive disorder, that's OCD, and obsessive-compulsive personality disorder, OCPD. Okay? And we've got the official diagnostic criteria straight from the DSM-5-TR. We'll look at treatments too, and crucially, what really separates them.
Perfect. Yeah, our mission here is really to unpack all of that, to give you a much clearer picture of what makes each one distinct. We'll cover like the main features, how they're diagnosed, typical treatment goals and methods. And I think this is key, how people with OCD versus OCPD actually see their own thoughts and behavior. Hopefully this clears up some of the confusion that's definitely out there between these two.
Okay, so let's kick off with excessive compulsive disorder, OCD. What's really striking about OCD is just how intrusive it feels.
Intrusive, okay.
The DSM-5 TRA criteria really zeroes in on this. It says OCD involves having obsessions or compulsions, or actually quite often both.
Okay, so let's define obsessions a bit more clearly. What does that actually mean in this context? Is it just worrying a lot?
That's a great question, because no, it's more than that. The DSM-5 TR defines obsessions as these recurrent, persistent thoughts or urges, or even images that kind of invade the mind, right? And they cause pretty marked anxiety or distress. The key difference from regular worries is that they aren't just excessive concerns about, real-life problems. They feel intrusive, they're unwanted, and the person actively tries to push them away, ignore them, or somehow neutralize them. Often that's where the compulsions come in.
Okay. So the compulsions are linked to the obsessions. What are they exactly?
Compulsions are basically repetitive behaviors. Things you can see like excessive hand washing, checking things over and over.
Like the stove example earlier.
Exactly. Or they can be mental acts, things happening inside the person's head like counting, maybe repeating words silently.
Okay.
And the person feels driven, like they have to perform these actions often according to really strict self-imposed rules.
And why? What's the goal?
Well, it's usually not about pleasure. It's aimed at reducing that anxiety the obsession stirred up, or trying to prevent a dreaded event or situation from happening.
Got it. So the obsession creates anxiety, the compulsion tries to relieve it?
Precisely. And for it to be diagnosed as OCD, according to the DSM-5 TR, these obsessions or compulsions have to be really time-consuming. How time-consuming? Generally, the guideline is more than an hour per day, or they have to cause clinically significant distress or impairment in important areas of life, like work or relationships, social life, school, just general functioning. It has to really interfere.
That makes sense. It's not just a quick thought. It's actually impacting their life negatively. Now, you mentioned this thing about how long it takes people to get help.
Yes, that was quite striking. While the DSM criteria don't set like a minimum time you have to have symptoms for a diagnosis, they just need to be persistent and not caused by, say, medication or another condition. The source has highlighted this average delay. It's about 11 years between the onset of OCD symptoms and actually starting treatment.
11 years. Wow, that's a really long time to be struggling. Why such a delay?
Well, the sources point to a couple of big factors. Shame and secrecy are huge. People often feel really embarrassed by these thoughts or behaviors, afraid of what others might think, so they hide it.
I can see that.
And then there's misdiagnosis. OCD can sometimes look like other anxiety disorders, or even just extreme worry, so it might not get picked up correctly right away.
Okay, so it's a combination of internal feelings and maybe external diagnostic challenges.
Exactly. It can be hard for someone to even recognize that what they're experiencing is a treatable disorder.
So Let's say someone does get diagnosed. What are the primary goals when treating OCD? What are they aiming for?
The immediate goals are usually about reducing the frequency and intensity of both the obsessions and the compulsions. And alongside that, improving overall daily functioning, reducing distress. Plus, addressing any co-occurring conditions is important, because things like depression or other anxiety issues often go hand in hand with OCD. The focus is often on relapse prevention building skills to manage symptoms if they flare up. And really importantly, increasing the person's tolerance for uncertainty and distress without resorting back to those compulsions.
Okay, learning to live with some level of uncertainty. And how do therapists actually measure if the treatment is working? You mentioned something about quantifiable goals.
That's right. Therapy often involves setting very specific, measurable targets. For instance, maybe aiming to reduce the time spent on rituals to less than 1 hour a day.
Concrete numbers?
Yeah, and tools like the Y-box, that's the Yale-Brown Obsessive-Compulsive Scale, are commonly used. It helps assess the severity of symptoms at the start and track progress throughout treatment.
Okay, got it. So, what are the main treatment approaches? What actually happens in therapy?
The cornerstone really is cognitive behavioral therapy, or CBT. The basic idea of CBT is looking at the links between unhelpful thoughts, feelings, and behaviors. And within
Right.
CBT, there's a very specific and highly effective technique for OCD called exposure and response prevention, ERP.
ERP. Okay.
That's considered the gold standard psychological treatment. Neurobiological factors are also understood to play a part.
You mean like brain chemistry?
Yes, particularly involving the neurotransmitter serotonin. Research points to dysregulation in serotonin pathways. This understanding supports the use of certain medications.
Like antidepressants.
Specifically, SSRIs, selective serotonin reuptake inhibitors, are often the first line. They help regulate serotonin levels, which can dampen down the intensity of the obsessions and compulsions for many people.
Okay, let's back up to ERP. You said exposure and response prevention. What does that actually look like in practice? It sounds intense.
It can be, yes, but it's done gradually and collaboratively. ERP involves systematically, step-by-step exposing the person to the very thoughts, images, objects, or situations that trigger their obsessions and anxiety. Facing the fear, but, and this is the crucial part, preventing them from engaging in their usual compulsive response. The response prevention bit? An exposure might be touching a doorknob they see as dirty, and the response prevention part is resisting the urge to immediately wash their hands for, say, an agreed-upon amount of time.
Wow, so they have to sit with that anxiety.
They do. And what happens over time, with repeated practice, is that the link between the trigger and the compulsive urge weakens. The anxiety naturally decreases on its own without the ritual. It's a process called habituation.
Okay, that makes sense. Challenging, but I can see the logic. What about the cognitive part of CBT?
Right, cognitive restructuring. That focuses more directly on the thinking patterns. It involves identifying, examining, and challenging the specific irrational or unhelpful beliefs that often fuel the obsessions.
Like what kind of beliefs?
Things like having an inflated sense of responsibility, feeling like you're solely responsible for preventing harm, or overestimating the probability of a threat, thinking a feared outcome is much more likely than it actually is, or needing certainty.
Right? Challenging those core assumptions.
Exactly. And we mentioned medications. Often SSRIs are used, sometimes at higher doses than for depression. If SSRIs aren't effective enough on their own, sometimes other medications like certain atypical antipsychotics might be added in low doses to augment the effect.
Gotcha. Any other approaches?
Mindfulness-based strategies are also increasingly integrated. They help people learn to observe their intrusive thoughts and feelings with a bit more distance and non-judgment, rather than immediately getting entangled with them or trying to fight them.
Let's take a quick break.
Want to know if you're ready for the real exam? Take our free practice test at licensureexams.com and see where you stand today.
Okay, so kind of acknowledging the thought without having to act on it?
Precisely. It complements ERP and cognitive work well.
All right, that gives us a really solid picture of OCD. Now, let's shift gears to the other condition, obsessive-compulsive personality disorder, OCPD. The names are so similar it's bound to cause confusion.
Absolutely. And it's one of the main reasons we wanted to cover this. While the names overlap, OCPD is fundamentally different. It's classified as a personality disorder.
Okay, so what does that mean?
It means it's characterized by a pervasive pattern, something deeply ingrained in the person's way of being related to orderliness, perfectionism, and a strong need for mental and interpersonal control.
Pervasive pattern, so like across many areas of life. The DSM-5 TRA criteria state this pattern usually begins by early adulthood and shows up in various contexts. And for a diagnosis, someone needs to display at least 4 out of 8 specific characteristics.
Okay, 4 out of 8. What are those characteristics? Can you run through them?
Sure, so number 1 is being preoccupied with details, rules, lists, order, organization, or schedules, often to the point where the actual purpose of the activity gets lost.
Okay, losing the forest for the trees? Kind of.
Sort of, yeah. 2 is perfectionism that actually interferes with completing tasks. They might get so bogged down in getting it just right, they never finish. 3 is excessive devotion to work and productivity, often excluding leisure activities and friendships. Work becomes everything. 4 is being over-conscientious, scrupulous, and inflexible about matters of morality, ethics, or values beyond what's typical for their culture or religion.
Very black and white thinking there. 5 is an inability to discard worn-out or worthless objects even when they have no real sentimental value. Hoarding tendencies can sometimes be part of it. 6 is reluctance to delegate tasks or work with others unless they submit to exactly their way of doing things. The control aspect again. 7 is a miserly spending style, hoarding money for future catastrophes, being very reluctant to spend on themselves or others. And 8, general rigidity and stubbornness, difficulty compromising or seeing other points of view.
Wow. Okay, that definitely paints a very different picture from the OCD symptoms we talk about, the specific intrusive thoughts and rituals.
Very different.
And the sources mention something absolutely critical here, the idea of ego-syntonic versus ego-dystonic. Can you explain that?
This is probably the single most important distinction. Ego-syntonic means the person experiences these traits, their perfectionism, their need for order, their rigidity as being consistent with their self-image.
So they think it's normal or even good.
Often, yes. They might see these traits as rational, logical, desirable, or simply part of who they are. They might even see them as virtues like being diligent or prudent. They don't typically view these traits themselves as the problem.
Whereas with OCD, you said it's ego-dystonic.
Right. People with OCD generally experience their obsessions and compulsions as intrusive, unwanted, irrational, and distressing. They conflict with their self-image. They know something is wrong or excessive, even if they can't stop it. That's ego-dystonic, inconsistent with the self.
Okay, so OCPD folks might think this is just how I am, and it's the right way to be, while OCD folks often think this isn't me. I wish these thought surges would stop.
That's a great way to put it. And you can immediately see how this difference impacts treatment seeking.
Yeah, if you don't think there's a problem with your traits, why would you seek help to change them?
Exactly. People with OCPD might come to therapy, but often it's because of problems caused by their traits, like relationship conflicts or trouble at work due to inflexibility, or maybe co-occurring depression rather than wanting to change the core traits themselves, at least initially.
That makes sense. And the DSM also mentioned that these OCPD patterns are enduring and inflexible starting early on.
Yes, typically emerging in adolescence or early adulthood and persisting. It's a chronic pattern unless there's intervention. And the sources also noted the role of culture.
How so?
Well, in some cultures or work environments, traits like extreme meticulousness, strong work ethic, or frugality might be highly valued.
Right, seen as positive attributes?
Yeah. So sometimes the problematic aspects of OCPD can be masked or even reinforced by the environment, potentially delaying recognition that it's actually a personality disorder causing significant impairment, especially in relationships or overall well-being.
Interesting. So if someone with OCPD does end up in treatment, what are the goals usually? It sounds different from just reducing OCD symptoms.
Very different. The focus isn't typically on eliminating specific obsessions or compulsions because those aren't the core issue. Instead, therapy aims to help the person become aware of their rigid patterns and the impact they have.
Okay, building self-awareness.
Yes. And then working towards reducing that overall rigidity, improving interpersonal relationships, learning to collaborate, compromise, be more empathetic. Enhancing emotional expression is often a goal too, as people with OCPD can sometimes seem quite constricted emotionally.
So more flexibility, better connections.
Exactly. Fostering flexibility and thinking and behavior, maybe reducing some of the workaholic tendencies if that's an issue, and addressing any comorbid conditions like depression or anxiety, which are common. It's less about symptom reduction like in OCD, and more about modifying these ingrained personality patterns to improve overall quality of life and relationships.
Okay. And what therapies are used for OCPD? Is it still CBT?
CBT can be helpful, yes, particularly the cognitive parts challenging rigid thinking patterns like perfectionism and the need for absolute control. But because we're dealing with deeper, long-standing personality patterns, other approaches are often integrated or used instead. Psychodynamic therapy, for example, can be very valuable.
How does that work?
It explores potential underlying conflicts, maybe stemming from childhood experiences related to things like autonomy, criticism, or self-worth, which might contribute to the development of these rigid defenses.
Okay, digging a bit deeper into the roots.
Exactly. Schema therapy is another approach that can be effective. It focuses on identifying and changing these deeply ingrained negative patterns of thinking and feeling, called early maladaptive schemas, that drive the OCPD traits.
Schemas, like core beliefs about oneself and the world.
And interpersonal therapy, IPT, focusing specifically on improving communication and relationship skills, addressing the interpersonal friction that OCPD traits often cause.
Can you give some examples of specific techniques used within these therapies for OCPD?
Sure. So in CBT, a therapist might work with the person to challenge all or nothing thinking about success and failure. Behavioral experiments could involve encouraging them to deliberately delegate a task and not micromanage it, to see that the world doesn't end if it's not done perfectly.
Right, testing those beliefs in the real world.
Exactly. Group therapy can be really helpful too, providing a safe space to get direct feedback on how their rigidity or control needs impact others and to practice more flexible social skills.
I can see how that would be valuable.
Psychodynamic techniques might involve exploring early relationships with caregivers, looking for patterns related to criticism or control. And schema therapy might use techniques like role-playing to help the person challenge their inner critic, that harsh, demanding voice driving the perfectionism.
Okay, a range of tools depending on the person and the approach?
Definitely. It's often a longer-term process than OCD treatment.
Right, okay, so we've looked at OCD, we've looked at OCPD individually. Now let's really crystallize those key differences.
So let's recap the main distinctions. First, just a core symptomatology. OCD is about those intrusive thoughts, images, urges, the obsessions, and the repetitive behaviors or mental acts, the compulsions.
All right, specific symptoms.
Whereas OCPD is about those pervasive personality traits, the intense preoccupation with order, perfection, and control. It's the overall pattern.
Got it. And the second big one we talked about was insight, right?
Yes, insight. Generally, OCD is ego-dystonic. The person recognizes the thoughts, behaviors as excessive or irrational, causing distress. OCPD is typically ego-syntonic. The person sees their traits as part of them, often as logical, normal, or even virtuous. They don't inherently see the trait as the problem.
And that difference hugely impacts treatment motivation.
Absolutely. It's a fundamental difference in how the condition is experienced.
Okay, what else?
Their DSM-5-TR classification is different. OCD is under obsessive-compulsive and related disorders. OCPD is under personality disorders in cluster C, the anxious, fearful cluster, which reflects the different diagnostic focus. For OCD, it's confirming obsessions and meritorious compulsions. For OCPD, it's identifying that pattern of at least 4 characteristic personality traits.
Okay, and do they tend to show up alongside other mental health issues differently? Comorbidity?
Yes, there are tendencies. OCPD seems more frequently linked with depressive disorders. OCD has stronger links with other anxiety disorders like panic disorder or social anxiety.
Interesting. And the treatment pathways diverge quite a bit as we discussed?
Significantly, OCD treatment often focuses on ERP and SSRIs, directly targeting symptom reduction, and can sometimes show results relatively quickly. OCPD treatment is typically longer-term psychotherapy, CBT, psychodynamic schema therapy aimed at modifying those deeply ingrained personality patterns, improving insight and flexibility. Medication isn't usually the primary treatment for the core OCPD traits, though it might be used for co-occurring conditions like depression.
So that affects the prognosis or the expected outcome too.
Generally, yes. OCD often responds more readily to targeted treatments like ERP. OCPD, being a personality pattern, usually requires more sustained therapeutic effort to achieve significant change. It's changeable, but it takes time.
Okay, what about neurobiology? Any differences known there?
There's more distinct research on OCD, pointing to things like serotonin system irregularities and hyperactivity in brain circuits like the orbital frontal cortex.
Right.
For OCPD, the neurobiological markers aren't as clearly defined. Some research links it to cognitive inflexibility, but there isn't a specific brain signature identified in the same way as for OCD.
Fascinating. And you touched on cultural interpretation earlier, especially for OCPD.
Yes, that's an important practical difference. Because some OCPD traits like diligence, meticulousness, thriftiness can be viewed positively in certain cultures or contexts.
Like a strong work ethic.
Exactly. It can sometimes be harder to recognize when these traits cross the line into a personality disorder causing impairment, especially interpersonal problems. OCD symptoms, being more overtly strange or time-consuming, are perhaps less likely to be misinterpreted as positive.
Right. And finally, how does the functional impairment, the way it messes up someone's life, tend to differ?
That's another key distinction. With OCD, the impairment often stems directly from the time consumed by rituals, the avoidance of triggering situations, and the sheer distress caused by obsessions.
It takes up space and energy?
A lot of it. With OCPD, while someone might be highly functional, even successful in structured work environments, the impairment frequently manifests in interpersonal relationships. Their rigidity, difficulty delegating, need for control, emotional constriction, and perceived criticism of others can lead to significant conflict with partners, family, friends, and colleagues. They might struggle with teamwork or intimacy.
Okay, so OCD impacts more via the symptoms themselves, OCPD more via the impact of the traits on relationships and flexibility.
That's a good summary of the general tendency, yes.
All right, let's try and boil down the absolute key takeaway for everyone listening.
Okay. The absolute core difference is this. Think of OCD as being driven by anxiety about specific intrusive thoughts, obsessions leading to behaviors, compulsions aimed at reducing that anxiety, which the person usually knows are excessive or irrational, even if they can't stop.
Ego-dystonic.
Right. Think of OCPD as a pervasive, lifelong style characterized by a need for order, perfection, and control, where the person often sees these traits as reasonable, logical, or even virtuous aspects of themselves.
Ego-syntonic.
Exactly. OCD is more about unwanted symptoms. OCPD is more about ingrained personality traits perceived differently by the individual.
So for you listening, really grasping that difference, the intrusive symptoms versus the pervasive traits, and especially that ego-syntonic distal piece, gives you a much sharper lens to understand these distinct experiences.
Absolutely. And it highlights why a correct diagnosis is so vital for guiding the right kind of help. The approaches are really quite different.
Definitely. Okay, finally, maybe a little something for you to mull over after this. Consider how much our society values things like high productivity, efficiency, organization, and, well, perfection.
Right? Those things are often praised.
So think about how those societal values might sometimes blur the lines, or maybe even inadvertently reinforce some OCPD traits. Even if those traits are causing someone private distress or creating real friction in their relationships, Externally, they might just look like someone who's incredibly conscientious or successful.
That's a really interesting point, how external validation or judgment interacts with the internal experience.
Thanks for being with us today, and remember, it's in there.